Well, thank you very much. Good afternoon, and thank you for inviting me here today to present the findings from our evaluation. I'm Fraser Battye. I directed the study and was due to present the findings with my colleague Nahid, who managed the study. But she's in the sort of throes of late pregnancy and has got an ankle that looks a bit more like a beach ball than perhaps you would want it to. So she can't be here today. So it's just me to talk you through the findings. We put together a presentation. It's in three main parts. The first part is just to talk to you a little bit about what we were commissioned to do and about how we set about doing it. The second part is the main part of the presentation, the main area of content, where I'll tell you a little bit about what we found. And then thirdly, I'll offer some reflections. Macmillan, and we were commissioned to evaluate the programme. And that's a really important point, since all of the things that you were, all the activities you've been presented to about today were sort of in our brief. And I'll come on later on to discuss how complex we found that. In a sense, we were given two broad aims. The first was to sort of document and to assess the programme, to look at what had been done, and then to look at the difference that had made for patients, and then also to the system. And as part of that, we were asked to look at the health economics of the changes that were made. The second main aim was to draw out learning. This programme is part of a broader system change programme that Macmillan are running. And so the aim here was to draw out lessons both for the programme in this area, but also nationally for Macmillan to build upon that. We conducted the evaluation between 2013 and earlier on this year, and we've got the final report is in draft with Macmillan at the moment. And you'll see on the slide, we evaluated all the way around the programme cycle. So we looked at the programme from the planning and design stage through to implementation, and then finally to look at the outcomes. When we were designing our approach, when we were thinking about the evaluation, we first of all thought, we turned up at the first meeting with the programme team, and they described what was going on, and a couple of us had sort of blood pouring out of our ears and couldn't quite cope with any more. So we needed to sort of take a step back and just make sure we could properly understand the programme. So in order to do that, we conducted a number of research tasks. We went through documentation and policy. We did a programme of stakeholder interviews. And then one of the running themes that's been in all of the presentations today is making sure that the patient voice is in there. So what we did in order to make sure the evaluation took account of patient interest is we conducted a focus group and also did a literature scan of what matters to patients in receiving these services. We combined each of these tasks in order to help define the programme, and the sort of summary definition we came up with was what we had here is a complex system operating within a complex system. We saw that the programme was an attempt at system change, and we also saw that there were different components operating in different areas at different times, with different aims, with different people involved, and with a wide-ranging set of expected results. We also saw multiple interactions between the programme itself and the system within which it was operating, the health and social care system. So you see, Tom, I think, introduced the theme of complexity in his presentation, and here we go. We saw the programme's defining features in terms of its variety, but then also its complexity. And in fact, within the programme team, we developed a complexity swear jar, so that every time someone said complexity, they had to put a pound in the jar, because it was just the overriding theme of the study. Variety and complexity present significant challenges for evaluation. Evaluation copes really well with stuff that looks like this, stuff with this sort of good linear pattern. So, you have some resources, you do some things, and the things that you do cause some result. Evaluation methodology is fine with this. Evaluation methodology is far less fine when the world looks a bit like this, which to our mind was how this programme looked and felt. I should say this is the famous diagram. This represents the causes and consequences of obesity. You can make public health types faint by producing this. So our understanding then was that system change is far more complex than this, it's a bit more like this, and we therefore needed some way in our evaluation of recognising that and of accepting the complexity and not just wishing it away. So we used a system map to represent the programme and to help organise our thinking. Now, believe it or not, and this is the truth, here's the simplified version of the map that we used to represent the programme and to help organise the study. I won't attempt to talk you through all of it, except to say what we have is sort of elements of the system. So here's secondary care, here is primary care, here is the voluntary sector. We have elements of the programme, so the green bits, this is where the programme is intervening. So intervening here in secondary care with things like holistic needs assessment, with wellbeing events, in primary care with one-to-one support, and many of the elements that you've heard about. And we needed a way of doing this so that we could look at patient flows, we could track patient journeys, and we could structure our evidence gathering with this in mind. In terms of the process we used for evidence gathering, we used a mixed methods approach. We gathered qualitative and quantitative evidence, looking to take different perspectives and looking to take views from across the system. There were four main elements to the evidence gathering stage. The first was a programme of stakeholder interviews. We conducted around 40 of those. The second was some economic analysis, which I'll come on to tell you about later. We also took account of programme data and information and evidence collected within the individual projects. But the bit I really want to draw your attention to was again an expression from our side of the intention of putting the patient at the heart of the study. And here we used a programme of peer research where we worked closely with the Western Park Cancer Centre to recruit people affected by cancer as peer researchers, to run a programme of training and support with them such that they could go out and do the patient interviews for the evaluation. I think as well as the system perspective which I just presented, I think there are some lessons in here for evaluation also. Before I come on to present the results, I want to say that the bulk of results I'll present actually relate to the work that Georgia presented earlier, in that we focus much more on the colorectal work going on in Sheffield because we saw that as the sort of purest expression of system change within the whole programme. So, the second part. Here are the main findings. First of all, I want to present findings from the stakeholder interviews, and we'll start in secondary care and work down into primary. Through the interviews, we found evidence of good progress in relation to improving the use of secondary care. We've already heard about the challenges of risk stratification, and we found that in practice it was actually a very challenging thing to do, and we have sort of illustrative quotes, and the one here, we thought in the beginning it would be clear, but in practice it's not. When we come to apply risk stratification, not so clear. We found that the holistic needs assessments had proved really useful and had become embedded in practice, and that they were helpful in relation to preparing patients for discharge, and also offered a framework for a conversation and for planning. And what we see here is a quote saying the consultation style is very different. It used to be around a medical model, but this is a care plan in the first instance, and it's structured around the patient. So again, many of the things that we've heard around wrapping care around the patient coming out there. As Georgia said, the Health and Wellbeing Day was very well received and evaluated very well. So that's secondary care. One of the common themes throughout many of the presentations this morning was about transition, and we found precisely that in our study also. Here we have the transition through into primary care. We found that embedding the new pathways in primary care has been much more difficult, much more tricky. There's much greater variety, of course. There's just much more of it, so of course there's more variety and it's more difficult. And that the other elements of holistic care in this area are still developing. We found evidence of significant capacity constraints in this part of the system, which will be news to no one. Also, that patient flows coming through the risk-stratified pathways to date had been modest, and so that wasn't yet embedded in routine practice. We found that Georgia reflected on how tricky it was and how it required a sort of lie down at the end. But the progress made with the treatment summaries provided a crucial bridge between secondary and primary care, and that they'd now become part of mainstream practice. We also found that the one-to-one support was vital in terms of the progress made, as was some of the learning and development and workforce development activities. And then finally we found it's early days in relation to embedding some of the more holistic elements, for example, the physical activity pathway. The other thing which I think is worth noting, and again I think it was positive to hear that the role was continued, was that the support provided to primary care at the point at which we did the research didn't feel so embedded that if that support was withdrawn, that practice wouldn't relapse back to business as usual. So I think positive to hear that element has continued. And I want to present the findings from the peer research and the views of the patients. The first thing to say is that patients were actually incredibly positive about their experiences in secondary care, and that also through the changes made in secondary care felt very well prepared for the transition back to primary care. There are common themes running through some of these quotes about the manner in which patients were dealt with, the information that they were provided with, all functioning to help them feel relaxed and in control and comfortable about that transition. I'll just take out the top quote. That they couldn't believe how easy it was to talk to the nurse, and that the information they gave them made them feel relaxed and prepared for that transition. Again, then, we come to this transition between secondary and primary, and a consistent finding from the patient interviews, as with the stakeholder interviews, that it was a slightly more mixed experience. In this, we found that the quality of the relationship between primary care clinician and the patient was basically the determining factor, where patients felt like they had a good GP or good care from the nurses. They felt like they were being taken care of. But where the experience was not so good, I felt like I was out on a limb. So again, it's the quality of relationship there. It's in the detail of that relationship between the clinician and the patient that seems to determine patient experience. Okay, and I want to present the findings from the economic analysis, and I'll do what all good evaluators and economists do, which is to spend a couple of minutes telling you why you shouldn't listen to any of the results before giving you the results. There are significant limitations in this analysis, and as brilliant as my economist colleague is, he only had sort of 4 or 5 days to produce this. So we're looking at a sort of first cut analysis. Nonetheless, our work does suggest that what we're looking at is that the changes in pathways that were described are broadly cost neutral. They don't appear to be cost saving, they don't appear to be costing any more, they appear to be broadly cost neutral. I'll tell you a little bit more about the analysis. What we did was a cost comparison analysis. So all we looked at was cost. We didn't look at any differences in patient experience or any differences in patient outcome. So some very significant things not included in the analysis. We also included a very, very wide range of costs. So you'll see we looked at cost to secondary care, primary care, the voluntary sector, transport. We looked at cost to the individual in time. We looked at cost to carers, and we also looked at cost to employers. I should say we modelled these results as well, so they're based on our estimates of what would happen rather than actually what has happened, since the numbers going through were too small. But what we see, as I said, is a change in distribution of cost rather than any increase or decrease overall. We see significant reductions in cost in secondary care and with hospital transport, offset to some degree by more marginal increases in cost elsewhere. Before I move on to the third part, I want to reflect a little bit about the experience in Doncaster, because I think it's instructive in terms of the lessons that we take forward for system change. The I statements and the co-production approach that Tom discussed earlier showed that the sort of power of the patient voice in the process of change. So that patients being able to say, this is what's important to me, and that the professionals advocating for those changes were able to say, we've done the work and we know that this is important, was a useful way of unblocking resistance and increasing the power of persuasion. I think it's also really interesting that the approach taken we could characterise as being about community development and about building on what's already there rather than creating new things and adapting the infrastructure and the resources that are already there. I found Tom's camel. It's in slide 14, bullet point 4 or something. The approach in Doncaster can be characterised as pulling in, creating the resources and pulling people into it, whereas perhaps the approach in Sheffield can be characterised as pushing out. So it's the most unusual equation I've ever delivered. I think Sheffield plus Doncaster equals promising, and I think from what we gathered in terms of the evolution of the programme, it actually appears that Sheffield plus Doncaster equals Barnsley, and that the future test bed for much of what has been learnt actually appears to be in Barnsley. So again, an unusual sentence, but the future does appear to be in Barnsley. Okay, so the third and final part of the presentation, I just want to offer some reflections about what all of this might mean in terms of future efforts for making system change and for the programme. At a general level, and thinking about system change in broad terms, this programme's generated a great deal of learning, and I've already reflected on some of the points. The first point is, and it came up this morning, is that system change takes a long time, longer than classic programmes, and in fact we've ended up recommending 5 to 10 year programmes of change rather than the classic 3 to 5 year timescale. We also think that system change requires particular approaches. So what we need here is leaders at all levels of the system, and I also want to reflect on the role of Macmillan in this process as an organisation with, I think, almost unique convening power to bring together organisations from across the system, and also to articulate the patient voice in the process of change. I mean, that's an almost unique role, I think, that Macmillan plays. Acting then as a leader of an agenda. People with storytelling ability. We're not necessarily always camel-focused stories, but people who could tell stories, who can engage, who can persuade, alongside the sort of more technocratic elements of running programmes. So we need people who can tell stories as well as people who know their way around prints too. We've also seen the power of patient-defined outcomes in helping persuasion, in helping engagement, and in helping influence. Here's Tom's camel again, but we see that a sequence combination of push and pull is needed, and that the approaches of working with what is there is very important. It's not come up much today, but I think the confidence of clinicians within the system is so fundamental. And the confidence of clinicians in secondary care, in a sense, to let go, and the confidence of clinicians in primary care to know that the systems and the support are there to take in. The final slide then is a series of much more specific recommendations for this programme as it moves into its next phase. I think these are the weakest recommendations I've ever produced. The first recommendation is keep going. I mean, the overriding take-home message from the presentations this morning is that the challenges posed by survivorship are growing, and they're not going anywhere. Moreover, the ability of the system in its current form to address it doesn't appear to be adequate. So the need for this type of programme is ongoing. The need for the sort of the rationale for action, the role for Macmillan remains. So recommendation 1, keep going. The second one is to provide a sort of sharper thematic focus with a far greater emphasis on learning. As I said, the programme at the outset confused us so much we couldn't sort of quite get our heads around it. The next phase of the programme, more tightly defined thematically, much stronger emphasis and much more deliberate emphasis on learning from action in the different areas. And then the final recommendation, which is why I say these are the worst I've ever written, because I used to not allow reports to leave the office if they'd got the more research is needed recommendation in. So here I am. But I think it's true. More research is needed. I mean, I said we were we were at the sort of first cut of the service economics on this, and it really did feel like it was quite a broad go at it. A much more detailed look at the actual service economics, the actual costs involved, and tracking some of that is incredibly important. And then finally, again, I feel like we were sort of on the cusp of getting a handle on the patient experience, getting a proper sense of what it was like to go through this revised system, but by no means have we provided a definitive view on that. And so work to properly track the patient experience over time, I also think would bear fruit.